Jacob Pendergrast, who is going to be doing our next talk. And he graduated in 1999 from Dalhousie in Halifax and completed his training in internal medicine, hematology, and transfusion medicine at the University of Toronto before working at UHN, where he's now the medical director of the blood transfusion service there. He's also been working as a clinical hematologist and treating patients with hemoglobinopathies in Toronto since 2004. And he's an associate professor at the Department of Laboratory Medicine and Pathobiology with a cross appointment in the Department of Medicine. He also holds a position as a clinician investigator at the Toronto General Hospital Research Institute and is a founding member of the Quest Research Collaborative, which focuses on issues of quality, utilization, education, safety, and transfusion practice. And his own research interests have centered on transfusion support for hemoglobinopathies, education, serology, and adverse transfusion reactions. So thank you, Jacob, for agreeing to do this, and I'm looking forward to your very thoughtful talk on TACO and how we can maybe influence some practice in the future. Thank you.
Thanks. Thank you so much, Andrew. Can I show my slides from my position in my Zoom perch?
I think you can show it on your Zoom perch. Do you have the ability to share it, Jacob?
I do. Just give me a second here to find the actual presentation. All right. Is that?
We can see it.
Perfect. Okay. Well, thank you so much. So yeah, I'll be talking about TACO and making my pitch for a dose calculator for furosemide. This is a similar presentation to what I gave recently at the Canadian Transfusion Trials Group. Apologies to those who are hearing it twice. I am granted a little bit more time, so I have fleshed out a bit of the background a bit more leading up into the proposal here. And I have no relevant disclosures. So if I accomplish nothing else in my career, I'm still very proud of this little acronym we came up with for trying to answer the question about whether we can actually use Lasix to eliminate transfusion-associated circulatory overload. It's certainly a common practice. And it's, there's definitely a need to do something about TACO, given how common it is. And as I think Christine made a good argument, and I think Andrew, you showed as well from your hemovigilance data, it's a significant cause of harm to patients. It's still, furosemide or Lasix as a mitigating strategy is not endorsed by professional guidelines. And I think that's in part because we don't really know how to dose it. And if we don't really know how to dose it, it's potentially dangerous. It is quite possible to over-diurese somebody and cause harm that way as well. So we decided to do a pilot randomized controlled trial of, what we thought was a reasonable dose of Lasix, which is 20 milligrams IV. And, the pilot was really designed, again, not to sort of prove that this dose was effective or assess it for not being harmful. It was just to sort of prove the feasibility of the protocol. And it was a pretty straightforward design. We took patients who were at high risk of TACO. So these were inpatients who were over 65, had a single unit of red cells ordered. And we randomized them to either get Lasix or to get a placebo. And then we waited to see what happened if they developed circulatory overload. And we assessed this by looking at changes in fluid balance, as well as looking at changes in BNP and chemistry. We did not have a protocolized process for investigating transfusion reactions per se, but certainly we had existing policies in place at the hospital for what to do if a patient had a hypoxic transfusion reaction, and that included getting a chest X-ray and doing a physical examination. And from that, we could then determine whether TACO had occurred and whether there was any difference in rate between patients who got Lasix and people who didn't. So I think one thing that we noticed right from the get-go was that there was a lot more resistance to enrollment in this trial than we anticipated. And, we weren't sort of doing a really thorough review of all the physician refusals all the way through the enrollment process for this trial. But, in the initial phase of this, we did find that, a quarter of the patients that we wanted to enroll, the attending physicians did not want their patients enrolled in this trial. And it was because they were so afraid that we were going to over-diurese these patients and cause harm as a result of that. And that kind of concern particularly came from the stem cell transplant program, as well as for patients who had undergone lung transplant. But in any case, we did enroll our target number eventually, to determine feasibility. And what we found was that there was a diuretic effect. You could see that the post-transfusion fluid balance in patients who got Lasix was about just under 400 mils difference. Not much difference in patients who got placebo, and that also was reflected in the pre-post change in fluid balance. We saw a statistically significant but maybe not clinically relevant change in BNP. There did seem to be a dramatic decrease in death, which I think is probably just a chance finding, given that we did not actually see any difference in TACO cases, between the two arms here. In terms of harms, there was, no toxicity per se. We didn't actually see anyone go into renal failure or anyone go into shock. There was a measurable change in potassium. Again, probably not clinically significant, but we saw that the Lasix was doing something. So, I think in terms of the question about whether this trial was feasible, the answer was basically no, because it took so long to enroll. And that was in part because clinicians just did not trust our assessment of 20 milligrams of IV Lasix being an appropriate, intervention to prevent TACO, even in this high-risk population. But even then, and again, we weren't looking at clinical outcomes. We were just, we were looking to see for feasibility. We didn't really see, much difference in terms of clinical benefit either. There wasn't much of a signal there. There was one case of TACO in each arm, negligible change in BNP. So the question was, was this even, the right dose? And I think something else to, point out, looking back here, was the enormous range in volume of diuresis. Yes, the average was about minus 379 mils, but you can see that the standard deviation was like, a liter and a half difference. So you could understand why the clinicians were maybe a little concerned that their patient might be the one who overly diureses and therefore is harmed. Similarly, there were probably some patients in here who did not diurese enough, and maybe that's why we didn't see much of a clinical benefit. So how did we come up with 20 milligrams of IV Lasix? Basically, this was just from a chart audit. We just, we looked at what type of dose of Lasix people were ordinarily ordering for their patients to prevent TACO. And most commonly, it was 20 milligrams. Some people gave 10, some people gave 40, but 20 was sort of right in the middle of the curve there. That seemed reasonable. Other, chart review studies had found the same thing. So that seemed like a reasonable thing to do. It is worth noting that it was not ordered frequently at all. Like only 16% of patients in this audit were given pre-transfusion Lasix, but that among those who were 20 milligrams seemed reasonable. But, do we actually know how to dose this? Like, what do we actually know about this drug? And the more you look into this, the more murky the entire literature on the pharmacodynamics of furosemide is. Early drug development studies found that if you gave 40 milligrams of Lasix as an IV bolus, you'll get about 3 to 4 liters of diuresis over 3 to 4 hours. And, we know about, the pharmacodynamics to know well enough, and I think our experience has shown that if you go higher and higher, there's diminishing returns because there's only so many drug binding sites. And so eventually, you sort of run out of diuretic response. But you will also have decreased diuretic response in patients. And again, this is just, everyone who's done internal medicine. Patients who have chronic renal failure don't respond as well. Patients who are on Lasix chronically don't do as well. Again, these are sort of actual trophic changes in the kidneys that make them less responsive. Patients who have decreased sodium filtration, if they're hypotensive, I think also importantly, if they have high colloid volume, all of these things low call avoidance tend to end up decreasing your response. And so, it has been found in practice that, a healthy patient might only need 10 milligrams of Lasix in order to get, a decent diuretic response, whereas another patient who has, all sorts of things leading to resistance might need 160 milligrams. So there's a lot of variability. And if you look in the monograph to find out, well, how do you decide how much Lasix a patient should get? No, sorry, I'll jump to that slide here. They basically say, well, why don't you start with 20 or 40 milligrams and see what happens? And if you don't get enough of a response, then give some more. And that's not really a strategy that you can use when you're trying to prevent a transfusion reaction. The idea is you want to give one dose and have that be enough, rather than sort of have the patient develop TACO and then give them more after the fact. As we know that you can't simply diurese away all the morbidity of TACO once it occurs. Even if the patient diureses, they may have at that point developed myocardial ischemia. They may have required intubation. So we want to get this right at the first try. And we'd also know, just looking at other trials of furosemide, that the range of diuretic that you get, even in a relatively homogeneous patient population, like these are trials of patients who had acute heart failure, was quite broad. Again, like on average, 40 milligrams of IV Lasix would give you about a 40 mil diuretic, but with some patients getting 2 or even 3 times as much of diuresis as that, and others not responding even to that degree. So that leaves us the question: okay, well, how can we figure out how to dose Lasix appropriately? And when you start looking into the literature about conducting dose-finding studies, you will discover that there has been a bit of a sea change recently in how these studies are supposed to be conducted. And that sea change is motivated mostly by the fact that many drugs fail in phase 3 clinical trials that seemed to do relatively well in phase 1 and phase 2 clinical trials. And this represents a huge wasted effort, obviously, in drug development. And one of the reasons they think that the phase 3 trials fail is that we go to those trials before we truly understand the pharmacokinetics and pharmacodynamics of the drug that we're studying. We have a sort of a very limited assessment on a smaller patient population for phase 1 and phase 2 trials, and then we go to sort of a more real world kind of environment with phase 3, and they fail. And the thought was, maybe we don't actually understand these drugs properly, and that's because we didn't actually do the dose finding studies properly. So the traditional dose finding study, which I think we're all familiar with, is you just randomize your patient population to different doses and you look to see which one is the best. And so if we were going to do that for a dose finding study of Lasix, we might say, well, let's look at like 20 versus 30 versus 40 milligrams, randomize patients to that, look how much diuresis each one puts out, and then we'll choose the best dose. And that's still how often things are often done in phase 2 clinical trials, but is again, the larger literature is suggesting is not the right way to do things anymore, and maybe is not what we should be doing when we're trying to find out the right dose of Lasix for preventing TACO. Maybe this is actually not going to lead to success if we do a trial like that. And why is this? Well, one reason is that you have many patients that you have to enroll to study different doses. The more doses you study, the less statistical power you have, and so you have to enroll more and more patients in order to figure that out. Also, very often, just sort of guesstimating at what a right dose is like, let's try 10, 20, 30, 40. These are sort of like, normal, increments that we sort of practice in, but it ignores all sorts of really important pharmacokinetics and pharmacodynamics that might influence the dose. And, we tend to sort of like round numbers, and, it's just really prone to bias to do this. And again, this is why phase 3 clinical trials often fail. And so we thought, well, if we're going to do a phase 3 clinical trial of Lasix to prevent TACO, maybe we should, do a proper dose finding study first. And so this quote here is from this workshop, and you can see this came out in 2017, where the attendees basically endorsed the idea that we should not be determining dose by actually testing a hypothesis that one dose is better than the other. That's not actually what we should be doing. What we should be doing is really modeling how the human body responds to the drug. And once you have that model, then you can identify the best dose. So again, the traditional dose response approach is you just take multiple different interventions and you just compare them. And your hypothesis is that, one will be better than the other. The other, approach to understanding how a patient is going to respond to a drug is where you actually do pharmacodynamic studies and pharmacokinetic studies, and you come up with sort of a dose response curve. But these are technically not done usually traditionally with statistical analysis. It's sort of an estimate, and they don't really come traditionally with any sort of assessment of how accurate it is, how precise it is. And that's kind of important. You actually want to know, like, how confident are you in this dose response curve that you generated? And so this new hybrid approach, which has been proposed, is called multiple comparison procedures with modeling. And here, what you're trying to do is take a set of predetermined types of dose response curves that exist for different types of drugs. And then you generate data looking at how your patients respond to different doses. And then you statistically map your response onto those existing dose response curves to see which one is the best fit. So it's basically a way of coming up with a statistically valid dose response curve, MCP mod. So not knowing anything about this literature or how to do any of this, it spent quite a lot of time just trying to find software that it could even do this, and a statistician who did know how to do this. And luckily, we have somebody at Sunnybrook Research Institute, Liying Zhang, who is fantastic and did know how to do the software analysis, and helped us with this. And so when you're doing this kind of assessment, you first of all, you choose your dose response models, and there's sort of standard models out there. This is all kind of baked into the software. There's typically like 6 or so that are kind of classic drug response models. Then you gather all your data to see what kind of dose response you get, and then you do your statistical analysis to see which curve fits the best. So again, what you're trying to come up with here is a statistically valid dose response curve, not an actual dose per se, just a dose response curve. And then once you have that, then you can do all sorts of things with this. So to do this, we decided that, we would just take patients who are admitted to hospital who are at high risk of TACO, because this is the patient population we really want to understand, how Lasix affects them, and just wait for their doctor to order them Lasix for some other reason. There's Lasix is prescribed so often, we didn't, need to enroll patients and consent them to get Lasix that they weren't otherwise going to be ordered. We could just wait for their doctor to order Lasix, and Lasix is ordered all the time for inpatients. And the goal was to take those patients, wait till they got their Lasix, and then measure how much urine output they produced, and then that would be how we would come up with our dose response curve. Now, we did know as well from looking at the literature that there are many different things that influence how responsive you're going to be to a particular dose of Lasix. Like I mentioned, what's your renal function? What's your albumin level? What's your blood pressure? Are you a chronic Lasix user? And so we gathered all that information to include as what you would call covariates in the formula that we were ultimately trying to generate. And so the covariates that we ended up choosing were patient age, the renal function, whether they were a chronic Lasix user, their mean arterial pressure, and their serum albumin. Fair question would be, why those covariates? Why do we choose those? And the short answer is because those come up over and over again in the literature as being important. And I have some slides kind of showing studies that show the relative strength of coefficient of those variables. And also they're relatively easy to get. They're not difficult to measure. In fact, they're often routinely being monitored for patients anyway. So they're practical. They're sort of feasible. The trick is that if you don't have any covariates, then you lose a lot of nuance in your dose response curve, and you lose a lot of statistical power, and you have to enroll a lot more patients. And you may never get precision because some of these things are so powerful. But if you have too many covariates, then it becomes really, too tricky to use. The math gets really complicated. It becomes, impractical. So we came up with these ones. This looked like a reasonable, practical set of covariates that had some literature to back them up. And again, we took patients who were at risk of TACO, and we had lowered our threshold age from 65 to 50, based on some literature suggesting that even over 50, there is an increased risk of TACO. We excluded, patients who had any clinical issue that would have excluded from a randomized controlled trial of pre-transfusion Lasix. So we wanted patients who weren't bleeding, patients who were not hemodynamically unstable. We wanted patients, who were, not in severe oliguric renal failure. We wouldn't expect them to respond to Lasix. Albumin was a covariate, so we needed to have patients who had that checked at least a week beforehand. And we didn't want this confounded by other diuretics. We wanted patients who were just getting the Lasix and had not received another dose of Lasix at least 12 hours beforehand or 6 hours afterwards. We took all patients who met these criteria and all doses of Lasix that they were ordered. Eventually, we found that there were so few patients being ordered Lasix for doses more than 40 milligrams that we just decided to cut the curve off at that level, because it was proving really difficult to get statistical precision at those high doses. Like, we were just never going to finish the trial if we wanted the dose response curve that high. So we did an interim analysis after our first 50 patients were enrolled, and we found that the average urine output they put out was about a liter, plus minus about half a liter. And based on that kind of variability, Liang came up with with a Bayesian approach, the estimate that we would need another 100 patients if we wanted to come up with a dose response curve that had statistical precision of plus or minus 100 mils. We thought that was a reasonable degree of precision to ask for. And so we ended up enrolling just over 150 patients. We ended up having to exclude a few because we didn't have enough urine output documentation. We only had change in weight, and we thought in the end that was not precise enough to really go by. So that ended up giving us 146 patients. And the most common doses, as you can see here, were 20 and 40 milligrams. But you can see right here, there was a huge range in diuretic response. Some patients were diuresing like just over 250 mils. Other patients are putting out like 2-3 liters of urine, like these all over the place. Again, kind of justifying the reticence of the clinicians when we wanted to enroll their patients in our trial, that we couldn't actually predict how much diuresis we were going to get if we just chose kind of a one-size-fits-all dose. Again, we decided that we were just not going to include patients getting more than 40 milligrams because there were just so few, and it made it really hard to model that high. We thought that we might have a little bit more of a dose response curve if we corrected for patient weight. And this gave us, some additional tranches of data, which is important. You want to have, a range of different dose response points on your curve to model it. But even when we came up with these, 5 different weight adjusted doses, you can still see there was really no clear signal of, diuretic response. And this is kind of not surprising because, the patients who are given the really high doses of Lasix are the patients that the doctors know are going to be diuretic resistant. So it's not surprising that they didn't actually put out that much more urine output. But even if there wasn't really a dose response, there was still this huge variability in how much diuretic. So we're just, it became increasingly clear this is a really difficult drug to work with. And again, you can sort of see why the ABB is not really endorsing Lasix as a TACO mitigating strategy. It's too chaotic a drug to use that way. However, when we did incorporate our covariates, then we actually did start to see a dose response curve. And this was very gratifying. I wasn't sure we were ever going to get here, but we did achieve a p-value of less than 0.05 with 100 mils precision for a dose response curve, which actually resembles what has been shown in other studies and in animals, which is this kind of diminishing responsiveness to Lasix as your dose goes up, because you have a limited number of drug binding sites. But it's totally modulated by, the patient's age, their sex, their GFR, their mean arterial pressure, their albumin, whether or not they're a chronic diuretic use. All these things are important if you want to predict how much Lasix, how much urine you're going to put out for a particular dose of Lasix. But if you do put those all things in there, then you actually have a pretty precise idea. So that was really exciting when we found that we could actually come up with a curve like that for this particular population of patients who are at high risk of TACO. So how would this work out in real life? So let's say you have a 55-year-old woman, 70 kilograms, GFR of 60, MAP of 60, albumin of 40, no chronic diuretic use, and somebody wants to give her a single unit of red cells. According to our formula, she should only require 10 milligrams of IV Lasix because that will produce, according to our formula, about 400 mils of urine output, which would be about right to offset a unit of red cells. Again, plus or minus 100 mils, but that should be protective without being risk of over diuresing her. On the other hand, if you had an 80-year-old man, 90 kilograms, GFR of 35, lower MAP, lower albumin, chronic diuretic use, and let's say somebody wants to give him 4 units of plasma, in order to offset that volume, in order to get a diuresis of maybe 800 mils, like maybe twice as much as what the previous patient, diuresed with 10 milligrams, this patient would require 80 milligrams of IV Lasix. So again, just to show that, it's not really going to work according to this formula if you take a one-size-fits-all approach of giving Lasix to eliminate TACO. It really has to sort of be patient specific. So the question is, what happens if you actually put this into practice? So again, we developed this formula in patients who were given Lasix, not patients who were transfused. And it's possible that the transfusion itself can modulate the response to the Lasix. There's all sorts of reasons why that might be the case. I mean, in terms of the vasomotor effects of free hemoglobin on nitric oxide, the inflammatory effects of fever. I think as Christine pointed out, it's not straight out Starling forces here. That there's a complex physiology. So the transfusion itself might modulate this. And also, diuretic response is not necessarily going to predict whether you develop TACO. We know that Lasix has other effects besides diuresis. It's itself a vasodilator. So even if you don't diurese as much as you expect, you may still be protected, from developing circulatory overload. So we really needed to validate this in real life to know if this formula can be applied to a future clinical trial. Also, it's not a formula that you kind of like rolls off the tongue involving sort of like logarithmic calculations and all these different coefficients. It would be nice if we could come up with something a little simpler, like maybe a point-based system that would be more practical in real life. So the study that I'd like to do next is to actually validate that dose response curve by choosing a dose of Lasix based on that formula and giving it to patients who are ordered a transfusion of whatever, whether it's red cells plus platelets, plasma, or what have you. And let's see, does it actually prevent Lasix prevent TACO, and does it do so without causing toxicity? And so the hypothesis was if we assume a baseline incidence of TACO in this population of 3%, can we get that down to 0%? of actual taco, full taco, without actually causing toxicity. And so to do this, we would be waiting for patients to not to have a Lasix order, but to get a transfusion order. But it would be the same patient population otherwise, same high risk group of inpatients, older, at risk of TACO. And we would look to see if the volume of blood products they were ordered was more than 250 mils. Then look for the same exclusion criteria, again, as an actual clinical trial of Lasix would be. And if they don't have any of these things, again, hopefully that's not going to eliminate too many patients. We then figure out how much Lasix to give them. And, we'll probably design an app for this. In the future, it might be possible to actually bake this right into electronic order entry, so that, it simply tells you, it pulls the data itself out of the chart and tells you this is how much Lasix you need. And, gives it rounded to the nearest 10 milligrams to make it practical, and give it right at the start of the transfusion and wait and see what happens. Look to see, is there any signs of circulatory overload in terms of vital sign changes, in terms of hypoxia. Look how much diuresis there actually is. Look at changes showing signs of toxicity in terms of hypokalemia, increased creatinine, changes in your proBNP. Very similar to what our pilot study would be doing. It was looking, sort of, at the delta in vital signs and these lab assessments to assess for TACO and adverse reactions. And so we want to find out, does it actually prevent TACO? Does it seem to work, just in a single arm study? And does it actually diurese the amount we want, which is also, of interest, maybe not as important as the rate of TACO, but certainly we want to find out, did we get the physiology right? And we'll be using, an ISPT definition of TACO, standardized definitions of adverse reactions, and again, looking to see whether there's actually, the volume of urine output that we thought was going to happen according to our formula. So I'm estimating it would take about 125 patients to prove that we can eliminate TACO using this formula, going from 3% to 0%. And I'm assuming that, we will see a little bit of hypokalemia, but not enough that would actually require us to do anything about. And we might want to build into this that patients who have maybe a baseline potassium below a certain threshold get a little, potassium supplementation at the time of the Lasix, just to get a little bit of a hedge there in terms of toxicity. And if it turns out that the amount of urine being output is totally different than what we thought, but the rate of TACO is still eliminated without toxicity, that's all right. I mean, we'll just adjust our formula accordingly. But so long as we actually were able to prevent TACO without causing harm, I think that shows that this kind of approach is the way to go. And we may find when we're looking through the data that we can simplify things a little bit. We may find that certain covariates are not that important. Like it may turn out, for example, that patient age is not as important as sex, which does appear to be quite important, or weight, and maybe we can drop that, and it may be possible to sort of come up with sort of a point-based system, that allows you to kind of, give incremental increases in doses of Lasix based on certain cut points, for example. That's the kind of thing that maybe a statistician could help us with. So once we have validated this formula and simplified it, then I think we will be in a much better position to actually do the full phase 3 randomized controlled trial of pre-transfusion Lasix to prevent TACO. And with that kind of, dose finding behind us, hopefully there'll be less reluctance on the part of physicians to enroll their patients. We can say, look, we are pretty sure that we can predict exactly how much your patient is going to diurese, so we're not going to hurt them with this. And we might very well protect them, from an adverse effect. And we can hopefully, by taking this approach, avoid the fate of so many other phase 3 clinical trials where they just fail. They just, you either don't achieve your outcome that you wanted, or it comes at too steep a price of toxicity. That would be a terrible thing, is if we did an actual RCT, a pre-transfusion Lasix, and ended up hurting patients, and that would sort of create all sorts of confusion. We want to make sure we're doing this right, so that we get the outcome that we want. This was my pitch to CTTG, or whoever else I decide I want to hit up for money to do this study. I think conservatively, it'll take a year to enroll 125 patients. But the actual cost of the drug and the cost of designing the app is negligible. So it's really just going to be coordinator time to dedicate to this. And obviously, the more sites are enrolling, the faster this would go. Okay, that's the end of my pitch, and happy to take any questions.
Excellent. Thank you for that excellent and thoughtful talk, Jacob. I will say it doesn't surprise me whatsoever that you and your group, when you explore this, became experts in dose finding studies. So it just speaks well to the variety of your expertise.
Mm-hmm.
Any questions from the group? Okay. No, speak, just project.
I'm surprised your app was just $120. Didn't the federal government spend $45 million on an app for? Anyways, that's all my question. I was intrigued by the mortality difference. 10 versus 2.
Yeah.
I know you said it's probably chance, but is it chance? Did you look at why those 10 people died, or any of them cardiovascular deaths? Is lowering potassium better? Any insights on that? Interesting observation.
Not really, no. I mean, we did look very carefully to see if they had, TACO, and they weren't dying of TACO. It was other things. A lot of those patients, in that pilot were oncology patients, and they were quite neutropenic. So there was a lot of, deaths from infection. I really, I would love to say, look, we 80% reduction in death with our dose of Lasix, but I think it was honestly a chance finding.
I'm just going back and forth between in person and online. So, Ali, I think I see your hand up.
Thank you for the great talk. I may have missed this, but I hope that the study also documents other types of transfusion reactions, not just TACO, because at the end of the day, we might see we're seeing less TAD, or even things that we might have been like classifying as trolley, and we see those things are actually decreasing with the Lasix dose, and that would be definitely an interesting finding.
Absolutely. Yeah. And I think, there's probably going to be all sorts of secondary outcomes that are of interest, just change in individual vital sign parameters. Is there any difference in rest rate, even if it doesn't meet the definition of TACO, any difference in hypoxia? So yeah, absolutely. We should be open-minded to any number of other outcomes that we weren't predicting.
Nancy, I see your hand up.
Yes. Thank you for a very nice presentation, Jacob. And also, I think the group from Toronto, yourself included, need to be congratulated on being the Canadian pioneers to solve the TACO problem. My question relates back to a master's student that I had probably about 12 years ago, who did her thesis, and her name was Jessica Fry, to give her the credit for this. But her thesis was just looking through a chart review at how often pre-medication was given to prevent transfusion reactions for different products. And at the same time, we had an anesthesia resident who was spending, I think, 2 months with training and transfusion with PED. And when she heard the preliminary presentation, she says, but Lasix isn't usually given before the first transfusion. They wait until after the second transfusion. I don't know if that practice still exists, but do you have any data, or can you comment on the fact whether, especially I look at your patient getting 4 units of plasma, should Lasix be given at the beginning Should it be given after the first, after the second? Is there any information out there about the actual timing of when it's given?
I don't believe there's ever been any like clinical evidence that shows it's better given at one time versus another, but certainly from sort of a physiologic rationale where we know, that its full diuretic effect, takes 6 hours, to kick in, that if you wait too long to give it, then the fluid challenge of the blood product itself, may cause harm before you can diurese it away. That's why we sort of recommended giving it, before the transfusion versus afterwards. I have seen also that practice of sort of, giving the Lasix kind of in between the transfusions. I honestly don't totally know where that practice came from. And I can't really think of a rationale for it. But I have seen that frequently as well. They sort of like to start the transfusion, then give a little bit, and then finish the transfusion. I guess the only argument I guess you could make for that is you may decide after that first unit of blood that the patient really can't tolerate anymore, and so you don't want to give that second unit. So maybe maybe your diuretic dose will be adjusted accordingly, maybe something like that. But I think I think it's generally considered to be best practice to just give it before you even start the transfusion.
I don't know where the practice originated, but 12 years ago, it may have originated in Hamilton based on this training. And I really don't know what the entire practice is currently around the province or within Canada. Might make an interesting survey.
I see a couple questions in the chat, a couple hands up. We might not be able to get to everybody in time, so maybe Jacob also encourage you to stay on and answer some questions. So I think I saw Mark McVeigh, you probably put in the next question. So just if you can, I wonder if you want to address that, Jacob. It's basically asking whether or not, it's solely through Lasix diuresis, which helps.
I'm not seeing his question in the chat here. Maybe I'm the wrong one.
I apologize. So it reads, do you think it's solely furosemide diuresis which helps? It's also known to have target anti-inflammatory effects. It sounds like you titrated the Lasix nicely, but what are your thoughts about including thiazide diuretics, potassium-sparing diuretics, osmotic diuretics, or carbonic anhydrase inhibitors?
Yeah, all fair questions. Yeah, I think whether the diuretic effect is the only or even the most important way that that Lasix might prevent TACO is for sure an open question. And I think that's why in the study I'm proposing here, we need to look at both things, both the urine output and the clinical endpoints, just to see if there is any correlation between the two. As to whether sort of like, you can get the same bang for your buck with other diuretics, I think that would be a really interesting question to establish after we have evaluated Lasix. If whether we can get Lasix to work or not, like the next question would be to say, okay, what about a different diuretic? But if we tried to do multiple diuretics in the same trial, I think it would just be a soup of too many confounding variables here to sort through. So we'll just start with the Lasix and go and see where that takes us first.
Maybe what I'll say, since we're going a little bit over, is Philippe, if I could just ask you to maybe type your question in the chat. Maybe Jacob, if you could answer Raz's and Philippe's questions in the chat. I just have one more thing for you. When you presented this as CTPG, I thought this was exciting, and I know so there was some discussion about whether or not this was initially a CTPG project, but I think we can all agree this is an important question to answer. And you're speaking to a bunch of folks who have interest in transfusion reactions and reducing them, and a lot of the data collection or a lot of the cost of your study is due to the data collection. If there are centers that are want to help engage in your study, maybe willing to put in a little bit of sweat equity, how can they help?
Send me an email. Tell me you're interested. The protocol will be provided to you for this.